Hello and a warm welcome to all of you on the second episode of Living Room Conclave India Health Mission Series. Now today we're talking about thalassemia. India has the largest number of children with thalassemia major in the world, about 1 to 1.5 lakh, and almost 42 million carriers of the thalassemia trait. Now in thalassemia, there is anemia, that is the hemoglobin in the blood, which is less than the normal level. This is due to the rapid breakdown of the red cells, a process called hemolysis. Now, according to the National Health Mission, approximately 1 lakh children with thalassemia major are born world over, of which 10,000 are born in India. Pained by these frightening numbers, Times Network, along with a panel of experts today, will explore the possibilities of providing a healthy life to those suffering from thalassemia major and talk about how it can be prevented in the coming generations. Allow me to introduce my guests. First up, we have Dr. Santanu Sen, Consultant, Department of Pediatrics, Pediatric Hematology, Oncology and Stem Cell Transplantation at the Conclave Dhirubhai Ambani Hospital, Mumbai. Dr. Sameer Tulpure, Consultant, Department of General Hematology, Hematolo-Oncology and Bone Marrow Transplantation at Conclave Dhirubhai Ambani Hospital, Mumbai. Dr. Mahendra Kendre, Assistant Director, State Blood Cell, National Health Mission, Mumbai. And Jasmine Majetia, Social Activist and Trustee, Parents Association Thalassemic Unit Trust, Mumbai. Ma'am, gentlemen, thank you so much for joining me here today. Dr. Sen, I'll come to you first. Like I mentioned, every year around 10,000 children with thalassemia are born in India, which is the largest number for any country in the world. So is genetic disorder the only cause behind this, or are there some other reasons also?
No, I mean, thalassemia is at its heart, it's a genetic disease. And as you rightly said, 10,000 children every year being born in India is a staggering figure, and we should try and do anything and everything we can to stop that. So thalassemia, as we said, is a genetic disease. So which means that if you have two parents and if both of them are carriers of the disease, then there's a 25% chance that their children will be born with thalassemia. That's at its heart is what thalassemia is, genetic disease. If your parents are carriers, then you have a 1 in 4 chance of being born with the disease. There are no other reasons for it.
Okay, that's important to know. Dr. Tulpule, so coming next to you, when we talk about, since it's genetic and it's carried out from your parents to the children, that's how you get it. Is there anything parents can do before they are expecting the first child or following children also? Some things that they can do to be prepared for the way ahead?
Sure. I think that's a very important question. We all know that thalassemia is preventable if we can basically be more aware of if the disease is prevalent in certain communities and around you. So the first thing I would advise is to first ask within your family itself, because a lot of times young people who are about to get married, their parents may be actually carriers of thalassemia. So just asking their parents may be a first step to just see whether they carry the abnormal gene. The second step is that if people are from certain community, they can get themselves checked by doing a simple blood count like a CBC. And typically if their hemoglobin is slightly low or the certain parameters are low, they can go ahead and check themselves with a specialist test to see if they are carrying that abnormal gene. And once they know, then they are more better informed in terms of who their life partner is going to be or whether they should be tested and so on. But these are more social questions. But coming to a personal, I think, decision, I think being more aware, getting oneself tested is probably the first step in sort of finding out whether one is prone to or is carrying the abnormal gene.
Okay, I want to talk to you a little bit about the tests, but I'll come back to you on that. Moving to Dr. Mahendra Kendre. Dr. Kendre, sir, the National Health Mission guidelines on thalassemia, they were published in 2016 by the blood cell of the MOHFW. What's your observation of what's happening in Maharashtra? How have things developed? How's these provisions, these guidelines, how have they been implemented in Maharashtra?
We have established 9 centers in the state for management of the hemophilia patients, and we are conducting the sickle cell control program in 21 districts, including all tribal districts of the Maharashtra. and the SBTC, that is State Blood Council, has issued the thalassemia card to the thalassemic patients. So accordingly we will diagnose these patients on the parameters like CBC, hemoglobin is less than 7 gram, MCH is less than 26 and MCV is less than 76. So we will suspect these patients as a thalassemics, and we will do the confirmatory test of HPLC. This HPLC test is available in all the districts through state government.
Jasmine ma'am, I'll come to you next. Ma'am, you know, in what earlier the doctors were talking about of thalassemia, and also importantly why it's important for people to get themselves tested so that they are aware about if they have the trait. You've been involved in this for many decades now and have been working really hard to create awareness. If you could share your thoughts on the role that NGOs are playing in combating and also creating awareness about thalassemia.
First thing, I go to the principal of colleges. Their children are educated. They can understand what you speak. So I talk to principal, take care of your children. Every final year, children should get this test done. They must know whether they are carrier or not before they leave the college. So it is the duty of principal to take care of their children. Okay? Number 2, when I see in poor children from Dharavi, they don't know what to do. So I tell doctor that for the gynecologist that you take care of the mother. When she comes for first time, get this test done, make it compulsory, so that newborn baby is carrier or normal, that they will say. So I went to Ambani Hospital, talked to them, CSR, that you take this project in your CSR and do BNT in lower cost. And we would collect money for these children, and 41 children are back to normal under 5 years or 8 years. Okay. So this is how we are trying to avoid all these things.
Great, ma'am. Thank you so much for sharing that with us. Dr. Tulpule, I'll come back to you. You were talking about tests, and Jasmine ma'am and Dr. Kendre also touched upon that. So this test, now again, if you're in a metro city, pretty much easily available. But what about rural India? These tests, if I'm talking not just smaller towns, I'm talking villages where awareness of this would not be there. Even if you go talk to them, like Jasmine ma'am was saying, the steps that their NGOs are taking. But are these tests easily available in villages, or would they have to go to towns to get this test done?
So I think I would come back to the thing that, you know, getting a complete blood count done first, getting more history to find out whether people are actually at risk of having thalassemia. And I'm sure that, as Mr. Kendre has put it, you know, with the network of our government primary health centers, they would have access to HPLC testing where they can get this done.
So it's actually kind of complementary because, I mean, right now, CBC is available, complete blood counts available almost anywhere you'd go. Okay. And if you look at a CBC, and especially with the background of a family history, if you get it, but if you find that there are certain parameters which are abnormal, then it's logical to think that is or can this be thalassemia, can this be a thalassemia carrier, and then take the logical next step and do the confirmatory test and figure out. And this huge steps has been done with various NGOs together with the government in this step, and they have been, all the NGOs including Patut, who's one of our partners, and they've been running these camps where they would take the actual HPLC machine at the point of contact to colleges, to army camps, to police camps, and run the test for the entire cadets or the entire students. And we give them a result straight away to let them know whether they are carrier of the gene or not. There's a little bit of an issue there that when you run this test where to a kid who's in class 12, who's 17, 18, 20, 21, 22, and you tell them, yes, you have a carrier, and it's important that when you get married, you should not get married to somebody who's also a carrier. The issue is that when after 5 years or 6 years, the time comes for that person to get married, A, he may not remember or he may not understand the significance of that result. And second, love is blind. Even if you know that your bride-to-be has a thalassemia minor, that may not stop you from marrying her, and that's very understandable, and that's an entire different thing that we need to address.
True, but I guess, the aim of this program is also just to create this awareness so people at least realize the importance of this and
Absolutely.
go in with all the information, so whatever decisions, at least they are informed. Dr. Sen, if we move now on from the causes and just the testing to treatment, how does treatment vary child to child or child to adult? Is it different for somebody who's a child and somebody who's an adult?
So the blood transfusion is something that will only make sure that you are fine, you are alive till the next transfusion comes along. It does not treat the patient. But when we talk about treatment, or rather when we talk about a cure, the only treatment or only cure we can offer our patients is by doing a transplant or a stem cell transplant. So transfusion services are now available to almost everybody at every level, be it at metro city, district levels, even in smaller towns, and Dr. Kendre can certainly talk about that in much greater detail than me. That's available, that's safe, and the best thing is that it's with government support, blood transfusion is available to every patient without any additional cost to the patient, which is fantastic. Right. But if we talk about a cure, which is the only cure we can do is actually offer them a stem cell transplant, then that is certainly variable, because a stem cell transplant is a very complicated procedure, and that's only really available in various metro cities, not certainly in the smaller towns.
Okay. Dr. Kendre, coming to you now, in Maharashtra, what's the role that blood banks have played to meet the blood requirements of thalassemia patients?
There are 320 component separation units. They have packed cells and platelets. These packed cells are used to the thalassemic patients, and each blood bank is mandatory to display their daily stock on the e-Raktakosh software and display it on their reception also. It is compulsory that they should also write that there is free blood for thalassemic patient in the reception of the blood bank. There are 19 thalassemia daycare centers established in the Mumbai, which was run by government and private organization, which was linked with the blood banks. These blood banks issue the blood to these 19 daycare centers as per requirement of the patients. And the SBTC is planning to give compulsory some certain percentage of the blood issue to the thalassemic patients. Right now, the National Blood Transfusion Council has given the 1% target of the total population. But in Maharashtra, we have collecting about 1.4% of the blood. That is, our population is 12 crore, and we are collecting 16 lakhs of the blood units per year. And our voluntary blood donation is 99.5%. And we are issuing the blood to all thalassemic patients as per their requirement.
I think right at the beginning of the program, I think you quite stressed that we are the large country with the largest population of thalassemia patients. And it is really a social problem. I mean, my colleague and myself, we see children with thalassemia and families really struggling day in and day out. Because patients coming in doesn't just mean transfusion for the child. It also means loss of livelihood for the parent who has to come in with the child and so on. So I think identifying this right at the root by doing HPLC testing, but I think as ma'am said, intelligent testing, by you do it with the CBC, find out who are the target patients who actually need the HPLC. So you don't do a blanket testing. You sort of try to restrict the testing to certain populations based on the community they are, the history they have, the blood count that they show. And those are the patients that ideally should have blanket sort of HPLC testing in those groups to prevent a birth of a thalassemic child who requires intensive treatment and transplant, as my colleague said.
And kind of like complementary to that would be that when our obstetric and gynecology colleague sees any mother-to-be, at that point, I mean, it's my personal opinion, but I think at that point when you are doing your screening test for any pregnant woman, perhaps we should really think of making an HPLC a part of that, so that if we find out that a mother-to-be has thal minor, then it's almost imperative we should test the father as well to see whether he also carries the gene. And if then we know both of them carry the gene, then we know that then the child-to-be may have thal major, may have thalassemia. Then we can actually check that baby before that child's born at about 12 to 14 weeks with a special test to see whether that baby-to-be will be born with thalassemia. And that's very important information for the mother, because then they can take a very balanced decision to say that whether she would want to carry on with the pregnancy, knowing that she would be bringing a child with thalassemia major into the world, or whether she would like to kind of like defer that decision and think of whether having another child in due course.
No, of course, definitely, because it's just again making people aware to take that educated guess, because I mean, nobody wants to see their child suffer. So if there is whatever they can do to help the child lead a good life, I'm sure any parent would want to do.
Absolutely.
As we wind up, just Dr. Sen, one last thought that I wanted is, you were talking about stem cell transplant. The beauty about science is that there is always so much innovation happening and things are getting better and better, maybe not immediately every day, but over a period of time, of course. Any developments here, any more new developments that are happening?
So it's actually a very interesting time for us transplanters doing stem cell transplant. I mean, before answering your question about new innovations, one thing I want to say is that there is always a lot of worry about stem cell transplants and whether it's accessible to the general population. And in this, I have to say that we've had a fantastic partnership with our NGO partners and the Government of India, the Ministry of Health and Family Welfare and Coal India, by which we have actually made a transplant accessible to thalassemia patients at no financial cost to them at all. So if we identify a patient with thalassemia who's got a perfect match, what we call a 10 out of 10 match in the family, then we can offer them a transplant where the parents don't have to bear the cost. It's actually comes out as a joint partnership with the CSR funds from Coal India, from Ministry of Health and Family Welfare. And it's been a fantastic venture it's been doing throughout India, and we are part of it, and we have started it. And I think that is amazing
That
thing.
has really,
of course,
changed the game.
Changed the game, saved many more lives than we could have done earlier.
Absolutely.
Fantastic. Thank you, ma'am, and thank you, doctors, for taking out your time and sharing your valuable perspectives with us. Well, that was indeed an insightful take on where India currently stands on its mission to combat thalassemia. It's true that India has many active cases for thalassemia, but what is also true is that both public and private organizations are doing their best in a joint effort to provide the best healthcare facilities to the needy. Well, that's all the time that we have on this episode. Don't forget to join me on the next episode of Living Room Conclave India Health Mission. Thank you so much for watching.